Okay, so we're going to switch to something very new, broadly neutralizing antibodies for HIV prevention and treatment. And I will declare a conflict of interest is that I don't think they're ready for use at the moment. What are they? Let's just go through that first. Well, they neutralize infection. They bind to this HIV trimer here, and they can also neutralize multiple strains of HIV. So the virological effects, if you look at a single BNAb, they do make the viral load go down depending on which one you use. You combine them, it looks like it's a little better, and 3 as well. But however, even with 3 BNAbs, and I'll show you some data later, most of the studies showed transient reductions in plasma viremia, and you get selection of resistant viral strains. And really, most of them have only worked very well on their own or in combinations of 2 if you started with a very low viral load. So in those persons with a very high viral load, they don't really do too well. And there have been viral rebounds without even selection of resistance. So it's very interesting how the mechanism of these is being understood at the moment. But one thing you can do with them, you can engineer them. And you can make their half-lives longer by affecting this. You can make a variant of various binding sites. This LS variant's one of them, and it can make them last very long indeed, so that you might be able to have even yearly infusions, okay, or quarterly subcutaneous doses. So one of the great hopes for these molecules are you can engineer them and even engineer them modifying, looking at what the patient's virus looks like, and then be able to give them subcutaneously. So the problem is that most BNAbs, you need to pre-screen the patient to see if they're resistant to them or not. And if you look at these lines here of all the cutoffs and susceptibilities, these look like they're not susceptible, and these are susceptible. And again, you look there. But look at this. These are people who virally rebounded, okay? But where is the cutoff along this BNAb? Is it there, or is it here? It's really difficult because both of these persons rebounded. And look at this group here. These did very well, but this one rebounded that. Where is the cutoff? Is it somewhere else? It's very difficult to know. And this is one of the problems with BNAbs. And you have to do a sensitivity test. And when you even do that, you have to understand where the cutoff rate might be to say, yes, we'll give it, or no. And because of that, you exclude about half of the people going in it. So for the BNAbs to be good clinically, you really got to have combinations of very potent ones, or engineering one, or you engineer them to attack various epitopes. But the problem is, imagine what the global diversity of circulating viruses are. I mean, every single mutation occurs every day in people who are viremic. So trying to do this is quite difficult. And also, you don't want to develop resistance to them. You also need some good pharmacokinetic profiles, because if you have to give them intravenously, they won't be any use to anyone in the world, because we're never going to move to even twice yearly intravenous drugs, even in places like Africa, Asia, etc. Even we would struggle with that. So it has to, in the end, be subcutaneous, and I think minimal, although I put 4 to 6 here, I think it's 6 months, and the cost is huge. So the cost has to be low. So imagine the bar that these drugs have got to go through in the next few years, right? They have to really work well. They have to have a good PK profile. They have to be very low cost. And they've got to really have a lot of protective levels of their activity over a long period of time. So what about in prevention and treatment? And I'm going to go through this now. Prevention as long-acting PrEP, and maternal child prevention as well. There's some data recently out, and then as treatments. Well, let me say, here's the big study of prevention and prevention trials. You can see here a couple of the big trials here that were done. And basically, if you look at the prevention efficacy in percent, you're not really going to do very well unless you're very sensitive to, right? You have an isolate that's very sensitive. But which doctor here in the room is going to be able to, in their PrEP clinic, and I saw a wonderful talk about, you can pick up PrEP anywhere, going to be able to take a blood, send it off to a lab, say, yes, you are sensitive to that BNAb, therefore you can take it, right? That is not just going to happen at all. So, but overall, so if you just take populations and don't select out specific people who are sensitive, you can see that actually it's not working. Okay. Sadly. What about breast milk and HIV transmission? There was a study recently at AIDS 2024 where it was just a proof of concept using 2 BNAbs administered subcutaneously in breastfeeding HIV-exposed neonates. And they were born without HIV and they're receiving standard of care, which I'm not sure what that should be anymore. But according to the US, okay. So, and then they gave the BNAbs, and it looked like they get very good potential protective concentrations. The levels are good. No children became HIV infected, and maybe what you could do is with children to prevent the breastfeeding transmission is give them single doses, and then maybe a second one at 3 months. So, but again, this is very technological, okay? And I can't believe that this would ever be anything you could do with the current technology for widespread use in neonates. So I thought I'd just find out what the experts felt. And there was an IR report in 2021 about the BNAbs and PrEP. So when they looked at the PrEP trials, at the Amplo trials, here's a question 1. Did the trial, the PrEP trial, show that a higher antibody titer than was expected will be required? In other words, we're not getting a high enough antibody titer from the drug given, and look at how many people said yes. In other words, they're underdosing. Number 2, how many BNAbs in combination do you predict will be required to prevent infection with the majority of circulating viruses? Most people said you need 3 BNAbs, okay. And there's some data on 2 BNAbs looking. I've just shown this graph, but I'll tell you that it showed some promise. But actually, these are experts in the field. We're not achieving enough level, and we need to give more BNAbs. And here's all these trials now going on. There are BNAb combinations for PrEP. Some of them are 3 and some of them are 2, and you can see here. So the field has moved towards giving 3 BNAbs for prevention. Okay. So I don't know what that's going to do with the cost, the manufacturing, or anything else to go forward. So I just see this as the very initial look at how BNAbs might work in the future, but I don't see that we can jump from this even in 5 years to be able to say that BNAbs are ready to give in PrEP. Now, what about BNAbs for treatment? And at CROI, there are all these studies, I've put them in yellow here, for BNAbs. There were single BNAbs. There was a single BNAb that covered 3 epitopes. There were dual BNAbs. There were BNAbs plus treatments, all of them. But basically, the problem was this. Number 1, when you screen people to see if they're going to be susceptible, there's a high failure rate. So a lot of them won't work in those people. Next, they did demonstrate that some of the patients could get adequate levels, but they could still fail. And it was really interesting that actually these BNAbs are not as good as antiretroviral therapy. So if I said to you, okay, you're the owner of a pharmaceutical company and you're coming along with a new drug to treat HIV, what is the gold standard at the moment? Well, we know what that is, right? It's at the moment, it's daily oral integrase. When you look at that as the gold standard of number of people undetectable, and I'll show you data from here that actually lots of these patients do fail with resistance, and some still, and obviously we can't be giving this intravenously. We really can't. So BNAbs in treatment at the moment are still very exploratory and experimental. Now, here's one of the studies with this BNAb, and they've all got telephone numbers, okay? They all have telephone numbers. So this one's been shortened to N6LS. And basically, they wanted to see if you give just for 11 days, what happens to the viral loads with various doses intravenously and subcutaneously. So here are all the doses. This one is subcutaneous. And basically, the subcutaneous dose, if you look in the change in the HIV RNA, hardly did anything, okay? It did as much as the very low dose BNAb. And the higher the dose you got, the more chance it was that you would actually get a response. And they said the problem with the subcutaneous was they think that you get lymphatic elimination of it. For some reason, it must bind to cells in the lymphocytes, and therefore concentrations aren't big enough. And if you look here again at the concentration curves, really, these people with lower baseline levels, right, susceptibilities needed less drug. So the more susceptible you were, the less drug you needed. But actually, it was really important, the sensitivity at baseline. So if you were very sensitive at baseline to this, you didn't need a lot of drug, which is obvious. Okay, so it's a real problem here. They are going forward with 2 more studies, this SPAN and EMBRACE, looking at intravenous N6LS. But I would say that I don't think looking at that, it really holds a lot of hope that we're going to be able to be using this in any way in the field. But I do think it's generating a lot of science. Right, so the next stage is, instead of just giving BNAbs, let's do something a little different. Let's combine the BNAbs with antiretrovirals. So it's like a triple therapy or a double therapy. So there are 2 things that were presented. This one here, which with lenacapavir, right, plus BNAbs, and this one with cabotegravir plus BNAbs. And these are where the BNAbs are affecting the binding sites. So let's have a look at that. So first of all, this lenacapavir plus BNAbs for people with HIV. And now, you had to be susceptible to either this terribly named drug, teripavilimab, or this other one, zinlirvimab, right? Tab or Zab. That's easier to say. So you had to be susceptible to one of them. So actually you were basically getting, right, 2 drug therapy. Even though you were given 3, 2 BNAbs and lenacapavir, you were basically getting 2 active drugs. And it was people who came in with a high CD4 count, and they didn't have a low nadir at all. So here we are, we're going to treat them now, and they're put into 2 groups. Why? They wanted to look at the dosing. They wanted to look at the dosing of this ZAB to see if you give a higher dose, it would work better. And then after this 26 weeks, you went back on your antiretroviral. You went back on antiretroviral therapy. Okay. Now, unfortunately, the problem is about the susceptibility. Okay, so, and we can see what happens next. So if you're susceptible to both, you do pretty well, okay? So that's all great. But if you're not, then you're in trouble. And what happened was, imagine if this was an antiviral trial with 3 drugs, and you had 2 virological failures, okay? So only at 26 weeks. So you already had, right, 18 out of 20 maintained viral suppression. This is the positive spin. 2 of them did not. 1 withdrew, and 1 had confirmed virological Wiebrand at week 16 and had to go onto oral ART. And this person had adequate drug levels and adequate sensitivity. So we're now getting into the issue of why did they fail with adequate levels, right? So they must have somewhere a virus in the proviral DNA that was not susceptible to any of these drugs that actually just outgrew and came out. But we don't know what they've done with that virus yet. So I'm not sure whether any of this lenacapavir and these 2 drugs will really be taken forward much from now, because I think that any study at 26 weeks where you get virological failures and you have to do so much testing before and you have to give it intravenously looks like it's quite difficult. And if you look, the people that did best were the people with the highest doses, these people here. Right? All of these remained undetectable. So you also have to manufacture a large dose as well. So the bottom line is, the higher the dose of your monoclonal, it looks like it's good, except the 1 failure had adequate levels. and it's quite complicated. Now, what about cabotegravir? So this was in 2 steps. So what they did, they got people undetectable for at least 2 years, and they switched them over to daily oral cabotegravir and 2 nucleosides to make sure they didn't have any problems with that. That's step 1. And then they gave them intramuscular cabotegravir plus this BNAB, which had been modified, the LS modification here. And they watched them for 48 weeks. Now, interestingly, if you look at the results, would you give a drug which had 7.3% virological failure rate? Would you give a combination of that? The answer is no. So it's, as I say, these are great experiments. They're really interesting. They had 5 virological failure events, and they're saying, oh, well, 2 of them had within 14 days of an Mpox vaccine. Well, we do know HIV viral load goes up, yeah, and with vaccines, that's true. 1 had a low-level viremia, and 2 actually resuppressed on a long-acting regimen, but it wasn't this one. Okay. So it's interesting that we're still not there with BNABs and antiretrovirals. So although people are doing quite a lot of interesting work, I'm not sure where we're going to go next with it in terms of combining it with oral drugs, because, or even long-acting injectable drugs. Because it may be that long-acting injectable drugs together are going to be better than any BNAB plus long-acting injectable drug. I don't know. So there was a review that came out of clinical infectious diseases. I put this in. I don't think they're ready for prime time. They're really interesting. But the limitation of broadly neutralizing antibodies and the current need for resistance testing at the beginning. So you have to do that. There's still unclear number of antibodies that must be combined. Well, the experts say in PrEP at least 3. The lack of penetration into anatomical reservoirs. Okay. And they basically, this group said they need considerable improvements before they can be considered. And I agree with all of that. But what can you do? Let's have a look at the future direction. So I've been very pessimistic. Yeah, I've been very depressive, and we can't leave the day being pessimistic. So let's try and get some optimism. Okay. So there are some new antibodies, and there was one showed at Croy which didn't work very well. Tri-specific, so you have one antibody that targets many of the epitopes, so you could do that. There's now entry inhibitor molecules that target this primary CD4 receptor and the co-receptor, so they actually prevent binding of the HIV virus there, that do both, right? So they do the CCR4 or CCR5 and the primary CD4. And also, almost all the BNABs are IgG classes. So they're now looking at BNABs that might be IgA or IgM, which is quite interesting. And the other thing they're thinking of doing is this. That basically, this is not in HIV, this is in chikungunya virus. But this is what they do. They basically do some vaccine, they do some priming of B cells, and this is the next thing they do. They get all these B cells put together, and then they improve things. And so what they want to do now is with mRNA, you can put mRNA in here, and you can start using it like a vaccine. And the mRNA codes for BNABs. So it may be very interesting that, we use a system that they've done in chikungunya to try and to produce antibodies as a vaccine, but instead of using it sort of like a drug, what you do is you use it like a vaccine. So the vaccine then produces BNABs. So that would be very interesting in the future to see if they can do that. And obviously, depending on what mRNA you put in there, it may be that you could make very diverse different BNABs all come out at once. So I don't know, again, about where this will go, but it's really interesting. And there's some, as I showed at the top there, human HIV-specific BNAB production after doing some adenovirus-mediated gene transfer. So there's a lot of stuff going on now, trying to make BNABs in a different way. And that would be great, because you don't need intravenous infections, and you may not need any baseline susceptibility, because you'll put such a broad range in that it will cover most of the viruses. So in conclusion, where are we going with BNABs? Well, I think for PrEP, it's a long way to go. I mean, they really, it really is very difficult. Maternal child prevention, I think that's quite interesting, because you may not need to do that for very long, right? You just do it for a period of time. If someone wants to breastfeed for, say, 6 months, maybe you could say, yeah, we could do this, or repeat it again. In treatment, I think in treatment naive, or even in, it's very difficult. I don't think we've seen any of the data that would recommend that we do that at the moment. And in switching combination with long-acting ART, well, it's possible, but we haven't seen really fantastic results. And with that, I'd like to say thank you very much indeed.